Thank you. Could you present the case to me, please?
So this patient presented with a Parkinsonian syndrome. This is evidenced by bradykinesia, rigidity and tremor. On assessment, I noted that power was preserved, as was sensation and coordination. I was unable to identify any features consistent with a gaze paresis, which would be suggestive of a progressive supranuclear palsy, and I was unable to identify any features which would be consistent with multisystems atrophy, such as postural or cerebellar symptoms. Ideally, I would have liked to go on to examine the patient further, looking for things such as their ability to write, looking for symptoms such as micrographia, and also asking her to draw Archimedes' spiral. It's important also to assess function in terms of things like doing up buttons to ensure that they're able to function in their day-to-day life. I believe this lady is most likely to have a diagnosis of idiopathic Parkinson's disease. This is a clinical diagnosis, and therefore there's no specific test required in order to make this diagnosis. It's important to take a thorough history, as this will help to eliminate some of the other differentials. For example, it would be important to ask specifically about any visual hallucinations or any cognitive dysfunction. If this preceded the onset of the Parkinsonian symptoms, then the alternative diagnosis, such as Lewy body disease, would need to be considered. Vascular Parkinsonism is another differential. However, this classically affects the lower limbs and presents with gait failure. I also wouldn't expect that to present with unilateral symptoms, and in this case, the right side was predominantly affected.
Okay, you've talked to me about the motor side of Parkinson's. What would you ask patients about non-motor symptoms of Parkinson's?
So there's a number of non-motor manifestations of Parkinson's disease. One of the earliest signs is anosmia, or the loss of the sense of smell. There's a number of other cognitive effects, which can be seen as well. There are also mood disorders, and a number of patients will present with pain.
Do you know anything about what sort of sleep disorders patients with Parkinson's can get?
So sleep is often affected, whether this is affected by problems such as turning over in bed, or whether they have broken sleep. Some patients will also have REM sleep disorders.
Okay. Let's say you had a patient with signs of early Parkinson's disease and they wanted to start treatment. How might you go about that?
So there's a number of medical therapies which can be used in idiopathic Parkinson's disease. These can start with things such as anticholinergics, also include COMT inhibitors, monoamine oxidase B inhibitors as well, and then dopaminergic therapies such as levodopa or dopamine agonists. They can be delivered in preparations suitable for the patient, whether that's tablets, patches, or dispersible preparations. It's important to consider the side effects of medical treatments when initiating them. Things such as impulsivity and disinhibition can be associated with dopaminergic therapies, and levodopa in particular is associated with on-off phenomenon and also with dose-related dyskinesias, and in these patients it's important to address the timing and the doses of the medications. Managing patients with Parkinson's disease requires a multidisciplinary approach, particularly as the disease progresses. Involvement of the occupational therapists and physiotherapists can help to retain the patient's strength and function and can ensure that the patient has any mobility aids or adaptations to the home or workplace that they need to retain their independence as much as possible. Again, as it progresses, speech and language therapists can be helpful to assess things such as swallow and to advise regarding diet.
Okay, thanks very much.